My name is Dr. Nwachukwu. I'm a medical officer in Cardiocare, our National Center of Excellence in Healthcare, Cardiovascular Healthcare. So I'm going to be doing a case presentation for a patient that will manage in our facility. Mr. SJVP admitted on the 30th of June and discharged on the 11th of July 2025. So Mr. SJV was a 65-year-old Indian citizen, known hypertensive diabetic of 5 years, who presented to our facility with complaints of epigastric discomfort and bloating, abdominal distension, and difficulty in breathing, all happening 1 day prior to presentation. There was no history of chest pain, no history of palpitations, no history of diaphoresis, feeling of impending doom. There was a positive family history of hypercholesterolemia. He does not smoke, does not take alcohol or use any recreational drugs. So this, just to talk about the history of presenting complaints, the epigastric pain, discomfort, said to be associated with nausea but no vomiting or changes in bowel habits. Abdominal distension also occurred few hours after onset of epigastric discomfort. And this said difficulty in breathing. There was also a positive history of orthopnea, PND, however, no palpitations or leg swellings. So on examination, this is just a brief summary of the case. On examination, he was a middle-aged man in obvious respiratory distress. He was dyspneic, febrile, 37.8 degrees, not pale, anicteric, acyanosed, not dehydrated, with bilateral pitting edema up to the mid-shin. His RBS on presentation was 7.4, pulse rate 134 beats per minute, small volume regular, no arterial wall thickening or anything suggestive of long-standing hypertension. The BP 114/72, he had an elevated JVP, and his apex beat was displaced and diffuse. Heart sounds S1, S2, S3 with tachycardia. On the abdominal examination, full moves with respiration, vague right hypochondriac tenderness noted. The liver was 4 cm below the right costal margin, no other palpable organomegaly. CNS, there were no remarkable findings. And in the respiratory system examination, the respiratory rate was tachypneic, 34 cycles per minute, saturating at 71% in room air, and then 93% on non-rebreather face mask. No tracheal deviation. On auscultations, there were bronchial breath sounds with widespread crepitations bilaterally. So I know, looking at this, our history and presenting complaints, epigastric discomfort and bloating, most people will think, oh, this patient is probably having an ulcer or dyspepsia or something like that. So, and then on further examination, our working diagnosis for this patient, we're thinking, oh, because of the dyspnea on at rest with orthopnea and PND, this patient could be in acute decompensated heart failure, NYHA, class 4, secondary to a query-dilated cardiomyopathy precipitated by a chest infection. Our second working diagnosis, we're also thinking about to rule out an acute coronary syndrome complicated by acute pulmonary edema, that's acute left ventricular failure with the KILIP classification. So we did some investigations. We did the troponin I, NT-proBNP, full blood count, CRP. So as a rule of thumb in our facility, every patient who comes in with chest pain, epigastric discomfort, they need to get an ECG within 10 minutes of presentation. So coincidentally, this particular patient on presentation, doing the ECG, we could see that this patient had obvious ST segment elevations in the anterior septal leads with ST segment depressions in lead 1 and AVL, and then also sinus tachycardia. So this is a classic case of anterior septal MI with some pathological Q waves in the inferior leads. On further investigations, we did a troponin I for these patients that showed 38.4 nanograms per mil. NT-proBNP, you can see the reference values. NT-proBNP 17,000. The full blood count showed absolute neutrophilia with a PCV of 44% and a platelet of 214. On the urea and creatinine, we could see that the patient has some form of AKI due to the elevated urea and creatinine levels. Lipid profiles, the LDL was okay, but the triglyceride was deranged. urinalysis, so 2 pluses of glucose, 1 plus of blood, uric acid 10, CRP elevated, ESR elevated. So the plan for this patient per protocol, we used dual antiplatelets, aspirin and clopidogrel, 300 milligrams start, then 75 daily subsequently. The role of statins should not be downplayed in management of MI, because apart from lowering the cholesterol levels, it also has anti-inflammatory effects and also plaque stabilization effects. So we use that. And then for anticoagulation, we used heparin, 5,000 IU 6 hourly. Some of us can ask, why heparin over Clexane? This patient was being prepped for percutaneous coronary intervention, and it's always advisable to use heparin in that case. Furosemide 80 milligrams, then 48 hourly, rabeprazole, ceftriaxone antibiotics, then the GDMT, spironolactone, and EMPA. The patient was then planned for an urgent CAG and PCI. And then following CAG, the patient was noted to have 50 to 60% occlusion in the mid left anterior descending artery, 99% stenosis in the distal LAD, diffuse lesions in the right coronary artery, and then 1 stent was deployed. The procedure was well tolerated. So subsequently, this was the plan post-MI. The patient was meant to have 75 milligrams of clopidogrel and statins for at least 6 to 9 months, high-dose statin therapies, IV normal saline infusion. Can ask why normal saline in this patient who is obviously in failure, to clear out the creatinines used in the procedure and to avoid metformin. On day 3, the patient was still breathless, however, was now on moderate exertion, no complaints of chest pain. He was weaned off ionotropes, had been ambulating, still felt bloated, was said to be resolving. Vital signs were all stable. He was no longer on non-rebreather face mask, now steps down to nasal prongs and saturating at 96%. Still had coarse crepitations in the mid and lower lung zones. At that point, the patient was transferred from the ICU and moved to the ward. We did a septic workup for him, changed his heparin to Clexane 40-12 hourly, increased his furosemide, and also placed him on suppository Dulcolax and Gestid to encourage liberal fluid intake and intermittent oxygen therapy. Subsequently, 4 to 6 days, the patient was doing very well. The chest x-ray done for this patient at this point showed cardiomegaly with clear lung fields. So it was obvious that the heart failure was resolving, and then the creatinine and urea were on a downward trend. However, the patient was still bloated, although it was said to be subsiding. The BP was stable, vital signs were all stable, and then the heart sounds 1 and 2 with tachycardia. The patient was now saturating at 95% in room air, residual crepitations in the right lower lung zones laterally. So our assessment was resolving decompensated heart failure secondary to DCM with background coronary artery disease. The plan was to increase the busuprolol to temporize on the euperio due to the low BP and to monitor vital signs. 7 to 9, the patient was still bloated. However, abdominal ultrasound showed distended bowel loops. Placed him on tenidazole as discussed with the gastroenterologist. By day 10, the patient was okay, bloating had subsided. Vital signs were all stable. We did a full blood count and UCR that had all normalized. And by day 11, the patient was discharged. Follow-up was done 2 days after discharge. The patient was doing well, and a back referral was wrote to the patient, who continued his management with his cardiologist in India. Thank you very much.